Hi, I'm Dr. Jen Peña, and I'm here to give you the scoop on all things sexual and reproductive health that are dominating your group chat. This is Doom Scroll.
Hey Jen, how you doing?
Hey Tessa, it's nice to see you.
So Oklahoma is one of the states that has the strictest abortion bans as of right now. But we also know that it is a state that has a very large American Native population and the access for emergency contraception from the Native American clinics.
I think the state has like 38 recognized tribes. So it's, again, one of the highest concentrations in the country. And so, there's different types of clinics that can serve this particular community. Some of the clinics are federal clinics, and then other clinics are clinics that are from the tribes themselves. And even though emergency contraception is part of the formulary for the federally funded clinics, it's not necessarily always going to be part of the formulary in the clinics that are at the tribal level.
I used to work for a tribally run clinic, and Indian Health Services, IHS, is a branch of the US government. So it's funded by the Department of Health and Human Services. The whole idea behind IHS is also that American Native and Alaskan Native populations are given the access to health care. So many tribes choose to enter into a 638 contract with IHS, and that means that they just get the funding from IHS to directly start up or implement their own healthcare clinic for their own tribe. And so I think a lot of the issue here is that, like you mentioned, for any IHS clinic, there is a national formulary, which is basically the list of medications that need to be prescribed at those clinics. But if you have your own 638 contract, it means that one, the benefit is that you get to provide whatever services might be especially applicable for your population of tribal members, but it also means that you or the tribe gets to determine what medications are provided. For many tribal members, their sole source of healthcare is going to be through these tribal clinics. But in a state where abortion access is limited and you don't have access to emergency contraception, it presents a huge challenge for these Native women.
On your experience, what would be those factors that come into play when the tribal clinics decide whether or not to offer, things like emergency contraception?
Something like 50% of tribes do have a contract with IHS that they provide their own healthcare. And so that's speaking to half of the federally recognized tribes, which is like close to 300. So each one is going to have its own reasons for providing or not providing certain services. It is also going to be very much population based. And so if a tribe is dealing with a lot of diabetes, it is very reasonable for that tribe then to allocate a lot of resources more toward support for diabetes care and maybe not so much on the reproductive health care.
Women in these communities that may be having these situations where they're lacking some of these sexual and reproductive health services like emergency contraception, there's alternatives now too, right? That they can explore if they happen to live in Oklahoma or one of these very restrictive states.
So even if a local tribally run clinic does not have the medication or the service available for a particular tribal member, there should still be an IHS facility within the surrounding area that someone can still access those medications or those services for free. Even if someone finds themselves in a position where their local tribally run clinic does not have a medication or a service that is offered, they can still look to an adjacent IHS clinic or facility, or as you mentioned, the telehealth option or a local pharmacy, or even online ordering is often an option too.
We couldn't have asked for a better lens into that healthcare world. So thank you so much.